Welcome to Expert Voices in Dementia, where thought leaders from the field present insights from dementia research, clinical practice, and caregiving that will help you maximize the quality of life and well-being of your patients. In this episode, Dawn Brooks, PhD, Global Development Leader, Eli Lilly and Company, and John Sims, MD, Senior Medical Director, Eli Lilly and Company, discuss new findings on baseline characteristics about amyloid-related imaging abnormalities, or ARIA, in people with Alzheimer's disease treated with donanemab.
The ARIA data is pooled data from Trailblazer, ALZ 2, and then the OLE. Tell me about what researchers discovered about ARIA from that data.
There's a few things that are confirmed, I think, across the class that we've seen regardless of drug, right? And that is that your genotype is important and carries an important amount of information for risk for ARIA. And by that, ApoE4, the homozygous, if you have two copies, right, you have the highest risk for ARIA. If you're hetero, you have a lower risk, and if you're non-carrier or the 2-3 copies, then you have some of the lowest risk. So that has been confirmed and seen over and over again. I think we feel very comfortable about what that genotyping tells you, and I think that helps provide a lot of the risk. The other data that we've also worked on and talked a lot about is and I think we're one of the few people that have done it still yet, and that is talk about your baseline MRIs, because everyone is going to require a baseline MRI, and that baseline MRI also provides quite a bit of risk, meaning that if we see signs that you have the amyloid that builds up in the brain also is building up in the blood vessel and is making the blood vessel unhealthy as well. So if you see signs of those microhemorrhages at baseline, you know that person also has higher risk. And the more you have, the more risk you have, which is somewhat intuitive, right? But so if you have no microhemorrhages, your risk is lower for ARIA. If you have one, it's higher than someone with none. If you have 2 or 4, it's even higher or so. There's another type of, this is all kind of in what we call cerebral amyloid angiopathy. These are signs on the MRI. So the other thing that we enrolled that other people didn't enroll that is a risk factor is the superficial cirrhosis. So there's another type of bleeding in the brain. It's kind of on the superficial cortex. And again, if you have one of those, you're also at increased risk of ARIA. And that is about equivalent to having, say, 2 or 4 microhemorrhages, that risk of bleeding if you have one superficial cirrhosis. So we've learned that and characterized that a little bit. Now it's been somewhat understood, and even from the bapineuzumab days about this, but we just got more data and we can characterize it a little bit better and understand these risks. The other thing that is probably not surprising is that the more pathology you have, probably the more risk you have, and we don't have good ways of looking at measuring the amyloid in the blood vessel, that CAA. That we don't have a tool for that. But what we do see is that if you look at the total amyloid load in the brain, it's probably a poor surrogate of also, for some people, how much is also in the blood vessel. And so, the good news is that if we get people earlier with less pathology, that risk also comes down, which again is another reason to make diagnosis earlier, because the risk, hopefully, of ARIA goes down. And on the flip side, efficacy seems to go up if you get earlier, which makes sense, right? The less the organs deteriorated, probably the more we have to save. The other novel thing that we hadn't seen before is that we had seen some indications that controlling blood pressure and people being on blood pressure management was also playing a role here in either increasing or decreasing your risk. This will need, replications and stuff, because we're the first people to discuss this and present it. And, obviously we'd like to see it replicated. And we are doing actually a whole study based on understanding ARIA. This is what we call our AACQ, or Trailblazer 6 is that study. That's fully enrolled just to look at ARIA, try to find new biomarkers that we might be able to find, people who have higher CAA. We put in novel MRI sequences in there to also look at CAA and things that we think might work in the future to help understand people's individual risk. So that study's ongoing, and we'll be able to say more. And so we'll certainly look for replication in that data set. But, this blood pressure aspect, if it's true, probably makes sense because ARIA is a vascular disease. And so we know that controlling blood pressure and things like that are helpful. It's the first time we looked at it, and so we basically just kind of did the simple terciles. If you ask me, I'm a vascular neurologist by training, I would tell you there's probably no magic cutoff, that higher is always worse, and that's generally true for cardiovascular, right? So more is worse than less. But, certainly you can create categories, and it looks like it's categorical the higher you go. And then those people who are on antihypertensives had less ARIA, which suggests that people were probably better managed for their blood pressure than the people who were hypertensive and not on blood pressures, right? So this is an area that will need lots of more data, and it's novel and maybe new insights and learning. So, and if it's true, then this is great, because this is another thing that a physician could manage. Actually, they should be treating their hypertension. Forget ARIA. People should have good antihypertensive treatment, right? It's good for heart and everything else. So it's just one more thing to reinforce that aspect.
And we would encourage this to be an individual benefit risk discussion, right, that a physician has. And we provide some of that guidance, ultimately within an approved label, but really it's an individual consideration. And so I think those risk factors that John outlined is part of mitigating that, is to understand, how you yourself, are coming into the situation. As John mentioned, knowing, doing the genotyping to understand your ApoE4 and getting an MRI are really, those two things can tell you so much about your own individual kind of risk profile potentially that you're coming into the potential treatment situation with, right? And then we have or expect to have MRIs that will be done at, prescribed points in the dosing regimen, which will give the prescriber, right, kind of that window into, okay, how have you done with the treatment, before maybe you have a step up in the dosing titration, right? So there's an opportunity there to proactively monitor, right? And then if you need to, do a treatment pause or take an action. So I think those are the two things I would particularly outline, is understanding individual risk and how you stack up against those baseline factors that John outlined. And even as that part of the conversation of benefit risk of starting treatment. But then there are going to be points where an MRI is done to monitor, right? And that will help to mitigate. I think once you're into, if you would be one of those, we talk about, 24%, most of them are going to be asymptomatic. You're only actually even going to see it if on the MRI that something has happened. There are, though, the cases of symptomatic and those, a handful of cases that are serious, right? That's uncommon. But then John could describe, if you're interested, right? If you actually got into a symptomatic ARIA situation where there are steroids and things that can be done to help to, kind of attenuate mitigate that. If you're into that more, much more minority situation. So when you talk about what are options, those are more reactive, right? But we hope that those other two aspects, understanding your baseline risk and right, having those monitoring MRIs will head off a lot of that. And the other things we've shown is that ARIA does primarily occur early in the treatment experience, right? So by the time you're to your sixth infusion, basically you're past kind of the ARIA that's going to happen. And so that's the other thing too, is those MRIs are particularly placed early kind of in the treatment paradigm, where we do see that most of the ARIA does occur, right? So that's the other thing too, is as a physician kind of understanding, what these patterns have been may help inform particularly that diligence early in the treatment experience.
Thank you to Dr. Brooks and Dr. Sims for sharing their knowledge with our listeners in this episode of Expert Voices in Dementia. And thank you to you, our listeners. Be sure to visit theneurologyhub.com for more podcasts in the field of neurology. Expert Voices in Dementia is brought to you by the editors of Practical Neurology.